So when we think about treatment of cutaneous vasculitis, I think one of the biggest challenges that we face is in first determining what is the underlying process, because that is going to guide how we approach management. This is not a uniform area, and we have to be able to think about this in terms of stratification. So what I'd like to begin first is providing some background in terms of the definition of cutaneous vasculitis, the settings in which this can be seen, the differentiation of isolated cutaneous vasculitis from a systemic vasculitis where cutaneous involvement is occurring. How do we assess that? And finally, in turn, how does all of this information reflect on the treatment approaches that we may take? So when we think about vasculitis, this is in fact a very general term which is referring to the presence of inflammation which is occurring within the blood vessel wall. When this occurs, the vessel can become damaged and go down one of two pathways. One is where there can be compromise of the vessel lumen leading to organ ischemia or infarction from loss of blood supply. Or particularly relevant in cutaneous vasculitis is that we can see thinning and attenuation of the vessel wall leading to either an aneurysm formation or breach of that vessel wall with hemorrhage into the surrounding tissue. When we think about this, I'm always struck that cutaneous vasculitis is actually one of the best examples of the histopathological and clinical correlation that we see in the area of vasculitis. And we can see in the image on the left-hand side, histologically within the dermis, these two small blood vessels that have become very damaged. We can see there's no blood flow occurring, but these are surrounded by erythrocytes which have extravasated into the surrounding tissue. So it's not surprising then that this is what we see reflected clinically as far as when patients have palpable or non-palpable purpura that's occurring as far as within the skin. Although we do think of purpura in terms of cutaneous vasculitis, as this audience is certainly very familiar with, cutaneous vasculitis can clinically present in a number of different ways. We can see necrotizing purpura, frank ulceration, we can see nodular lesions, urticarial vasculitis, just to name a few. This is very important, though, because out of all of medicine, cutaneous vasculitis represents the most common vasculitic manifestation that any of us will encounter during the course of our careers. And this can occur in a variety of settings. In about 30% or less, we may find that there's no identifiable cause or disease that is outside of the skin. But in the remaining 70+% of these patients, the cutaneous vasculitis is occurring in the setting of an underlying trigger or process. This can include a medication, an infection, and as we can see here with the example of cryoglobulinemia, this could actually be either as far as a setting where there's an infection, such as hepatitis C, or it can be associated with multiple myeloma. We can also see this in a range of underlying inflammatory diseases, or this could be a heralding feature of an underlying primary systemic vasculitis. When we think about the vasculitic diseases, historically these have been grouped according to the predominant size of vessel that's affected, and this continues to be the case in the most recent nomenclature system published in 2013. While all forms of primary vasculitis have the capacity to be associated with cutaneous features, the ones that we see most commonly include those that affect the small to medium size of blood vessels. The challenge we face is in differentiating those that have systemic manifestations from those that are isolated to the skin. This has importance because, again, of our main topic today, which is how do we approach these therapeutically. And the very first step in determining an approach to treatment is to establish if the cutaneous vasculitis is occurring in isolation or in association with an underlying trigger or disease. We can certainly understand this, again, when we look at this list of underlying processes. In the case of a medication-induced vasculitis, the step would be to discontinue that trigger. In the case of an infection or an underlying malignancy, treating the underlying process often addresses the cutaneous vasculitis. And similarly, when there is an underlying inflammatory disease, as we've been hearing about at this conference, such as with Crohn's disease, rheumatoid arthritis, or lupus, or when this is a heralding feature of a primary systemic vasculitis, treating that underlying process, again, will address the cutaneous vasculitis. The diagnostic assessment is important not only for this reason in determining the best treatment approach, but also in detecting manifestations that may threaten other organs. So when we think about the recognition of serious disease and we look at the organ targets that can be affected by vasculitis and our best strategies to identify these, we can see that the vast majority of these we can detect in terms of symptoms and signs by a thorough history and physical examination. But the other concerning thing that we can see from this table is that there are manifestations that can affect the lung and the kidney that may not be readily apparent on initial discussion with the patient and is really detected in vigilance and looking further into labs and imaging. So in the case of pulmonary vasculitis, up to 1/3 of these patients may be completely asymptomatic. So they may have no cough, there may be no shortness of breath, and even in the case of early alveolar hemorrhage, these patients may have no hemoptysis. But this can be detected by imaging, where again we can see single or multiple cavities or infiltrates or nodules, and again, most concerningly, we can see ground glass infiltrates in the setting of alveolar hemorrhage. This is even more pronounced when we talk about renal vasculitis, where patients essentially have no symptoms directly related to the kidney. This is painless. The urine continues to appear yellow. The concerning feature, though, is that this can be rapidly progressive and can lead to renal failure. So this is really detected by the urinalysis, which remains often one of our most underappreciated tests in vasculitis, where we may see hematuria, dysmorphic red blood cells, or the presence of red blood cell casts. And we can see here in this histology one being formed in the tubule right next to this very crescentic and damaged glomeruli. So when you see a patient with cutaneous vasculitis, what are the most immediate issues? Well, we want to confirm that this is indeed vasculitis and recognize if this is a patient who's in a potentially threatening situation. So how do we do this? Well, again, I think as this group is very familiar with, purpura is not equivalent to vasculitis, even though I've mentioned this. And there is a whole range of different disease entities that can present with a purpuric appearance. One case in particular I'll never forget from my fellowship was a patient where we were called to assess the individual for a possible cutaneous vasculitis, and a very astute dermatologist looked carefully, did a biopsy, and determined that this was a case of scurvy. So the keys to an immediate assessment, again, what are our clues from our history, our physical examination, radiographs, and again, in a patient who presents with a cutaneous vasculitis, even in the absence of features, I would encourage a chest radiograph to look for evidence of pulmonary involvement. And then in terms of laboratories, in many ways, our most basic tests are our most important in terms of looking at renal function, blood counts, a marker of inflammation such as the sedimentation rate and or C-reactive protein, and then the urinalysis. And if there is blood present, we want to know their renal function immediately. Now, there are also a range of other serological tests that can have great utility when targeted in thinking about different diseases. So these might be helpful, again, in the setting where you've heard about as far as with patients who present with lupus, with Sjogren's syndrome, with myositis, or with scleroderma. And in the case of the primary vasculitis, the serology that often is discussed is in terms of the anti-neutrophil cytoplasmic antibody, or ANCA. This antibody was first described in the 1980s and has been found to have two main immunofluorescent patterns. In vasculitis, the cytoplasmic staining pattern corresponds to proteinase 3, a 29 kD serine protease found in the eosinophilic granules of neutrophils. There is also a perinuclear staining pattern, which again in vasculitis corresponds to another neutrophil enzyme, myeloperoxidase. Now, this is important because ANCA can be associated with particularly the small vessel vasculitides. And in the most recent nomenclature scheme, there were 3 entities that were defined as ANCA-associated vasculitis: granulomatosis with polyangiitis, Wegener's microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis, Churg-Strauss. And we can see when we look at this, the predominant pattern that we see is proteinase 3 C-ANCA in the case of GPA, while MPA is more tightly associated with myeloperoxidase P-ANCA. But what we can also see is that in up to 20% of GPA and MPA, patients may be ANCA negative, and although EGPA is considered within the ANCA-associated family, up to 60% of these patients may be ANCA negative. In addition, there are other forms of vasculitis that can be associated with cutaneous vasculitis and giant cell arteritis, which is the most common vasculitis that affects us as people. ANCA is almost never seen. So this reminds us as far as that a negative ANCA does not rule out vasculitis, and particularly again for some of our cutaneous patients. And similarly, a positive ANCA should not be equated with a diagnosis of vasculitis, as this can be seen in other settings. So in looking again in our schematic, I do want to just highlight some of the differences as far as how these diseases that can share cutaneous vasculitis can have very divergent clinical and also therapeutic considerations. And we'll again highlight the ANCA-associated vasculitis family and compare that with IgA vasculitis, formerly known as Henoch-Schönlein purpura. So in the case of GPA, this is characterized by its histologic and clinical features, in which we can see granulomatous inflammation, vasculitis of the small to medium-sized vessels, and aposteimmune glomerulonephritis, and where there is predominant involvement of the organ triad of the upper airways, lungs, and kidneys. Now in these patients, the skin can be affected in at least half of these patients. Its sister illness, microscopic polyangiitis, again, another pulmonary renal syndrome in which we can see a predominant effects as far as with the lungs and kidneys. Slightly higher frequency here of cutaneous vasculitis of about 65%. Now in 2018, the good news is that we have a wide range of treatment options for these diseases. We can see that this is first stratified in terms of the severity of the disease, where patients who have active GPA or NPA, if there is severe involvement, have the options of cyclophosphamide or rituximab anti-CD20, while non-severe disease can be treated with methotrexate, all in combination with glucocorticoids. Following the initial treatment, as far as where active disease is put into remission, which is considered an induction period, these patients are then put on a maintenance regimen for at least 2 years or longer, which can include both conventional agents such as methotrexate, azathioprine, or to a lesser degree mycophenolate mofetil, and increasing data with the use of rituximab as maintenance as well. Now, the reason these are very aggressive treatments that are used is because these are life-threatening diseases, and this is not an entity where we have the option of observation and seeing how these people do. We know from the time prior to where treatment was available that this disease had a mortality rate of average of about 5 months. But the good news currently is that, again, these are very effectively treated and can now be considered chronic diseases. But early diagnosis is critical in organ preservation. In contrast, EGPA is a very different disease, even though, again, it's considered within the ANCA-associated family. This is thought of as having 3 phases: prodromal phase with asthma and allergic rhinitis, eosinophilic phase where we can see peripheral and tissue eosinophilia, and then vasculitis, which can affect a wide range of organs. The skin is a very predominant site of involvement, and we can see here again on this biopsy a lot of eosinophilic staining. And in this series from France, published in 1999, we can see that skin involvement occurred in 51%, with, again, a diversity of clinical manifestations from purpura, nodules, livido, ulcerations, which can occur. In the case of EGPA, again, this is a very different treatment approach than with GPA or MPA, where prednisone alone can be used in many instances. Severe disease, such as that threatening the heart or the kidney, would be treated similarly with prednisone and cyclophosphamide. And then the most recent therapy has been the use of mepolizumab or anti-IL-5. This was examined in a randomized trial published in the New England Journal in 2017. This was an important study, but also important to recognize that severe vasculitis was excluded, but this may have a role in cutaneous vasculitis, potentially those, again, who have recurrences. The prognosis in EGPA is influenced by its severe disease, and cardiac involvement is actually the major cause of mortality. Asthmatic relapses are common, and vasculitis relapses can occur in about a third, and in particular, this can include cutaneous manifestations, and I have a number of patients actually where that's one of their predominant features that they need treatment for. Now, in contrast, IgA vasculitis, or Henoch-Schönlein, is a disease that predominantly affects children 75% before the age of 8 years. But it can definitely occur in adults, where the disease may be both more challenging and more severe. The 4 cardinal manifestations include arthritis, glomerulonephritis, GI involvement, and purpura. And skin involvement occurs in over 95% of these patients. And when a child presents with purpura with some of these other features, this is usually a fairly straightforward diagnosis. It is not so much, however, in adults, and this can be important as far as performing biopsy with immunofluorescence, where we may be able to catch IgA deposits in early lesions. Treatment is rarely required, and this is often a self-limited disease. There's some data to support that glucocorticoids may reduce the arthritis and abdominal discomfort. And in contrast to what we talked about with GPA and MPA, cytotoxic therapy is rarely used, maybe for those that have a more progressive loss of renal function. And there's no current role for biologic agents. This is associated with a low rate of mortality. End-stage renal disease occurs in 2 to 5% of children, but up to 13% in adults, such that monitoring the renal picture is particularly essential in adult patients. Relapses are actually quite common, and in particular cutaneous relapses, and this is again patients we do see in the clinic. So how do we treat these recurrent cutaneous vasculitis relapses in IgA vasculitis? Well, it's similar to isolated cutaneous vasculitis. So how is that? And again, I think one of the things we realize when we talk about isolated cutaneous vasculitis, this is often extremely difficult to treat. Part of the challenge we face is that there is no evidence-based optimal therapy, and the general principle is to use the least toxic yet hopefully effective approach, recognizing that the side effects of the medications may in some ways pose a greater risk than the disease itself. We do have a range of different options. Observation does remain a possibility, and there are patients that I will have a discussion with as far as if they have relatively little discomfort, they're not disturbed as far as by the appearance. Again, we don't see any evidence of systemic involvement. They're actually more fearful of the medications and the side effects than the lesions themselves. The next rung of treatment ladder, if you will, includes agents like nonsteroidal anti-inflammatories, colchicine, which would be contraindicated in renal insufficiency, dapsone, again contraindicated in G6PD deficiency, hydroxychloroquine, pentoxifylline, or low-dose glucocorticoids, which in many ways should be considered almost a level in itself. Now, at the other end are more immune suppressive medications, such as azathioprine, methotrexate, mycophenolate. Cyclophosphamide, again, I would say should very, very rarely be used. The only settings in which I have is when, again, I have patients that have severe ulcerating disease, where the morbidity, such as an infection or risk of osteomyelitis, justifies the use of that medication. How we decide as far as which of these treatments to use is often individually considered, weighing as far as the contraindications for that individual patient and potentially their past treatment history if they're having relapsing disease. Now, the exciting news that we have on the forefront is that we are going to be seeing, as far as in the near future, the conduct of a multi-center randomized trial called Aramis that is going to compare colchicine to dapsone to azathioprine. This is being led by Dr. Micheletti and the Vasculitis Clinical Research Consortium, and Dr. Fernandez in our Vasculitis Center will be participating in this study, which we're excited to see. So in talking about novel therapies, what is the role of biologic agents? And as we've already alluded to, biologic agents do have a potential role in the management of when cutaneous vasculitis is occurring in the setting of an underlying systemic vasculitic disease. So in the case of GPA and MPA, I already mentioned rituximab, which is FDA approved for these indications. In a randomized trial, this was proven to be as effective as cyclophosphamide. And in this setting, again, we would weigh the risks and benefits as far as using rituximab if this was solely for cutaneous relapses. But again, very frequently it's accompanied by other features that would justify its use. Abatacept, or CTLA-4 Ig, has been shown as far as benefit in a 20-person open-label pilot study in patients who had non-severe relapsing GPA, which again, cutaneous disease would fit into. This is now the focus of a blinded randomized trial, which will hope to determine further utility as far as its efficacy. Another novel agent that is under investigation is avacopan, or anti-C5R, which is not FDA approved currently for any indication. This is being examined in clinical trials as a steroid-sparing approach, and there's been one publication examining this from Europe. In the case of EGPA, again, I mentioned previously about mepolizumab, which is FDA approved. There has been a small amount of data with rituximab, and again, this is important to, again, differentiate EGPA from GPA and MPA in that, again, these are phenotypically very different, and actually the body of evidence for the use of rituximab is actually quite different in this setting. So what about those patients that have isolated cutaneous vasculitis? And biologic agents really do not have a clear and current role in the management. When we look at the data, the use is actually limited to case reports, and if you actually do a PubMed search, you're much more likely to find case reports as far as where biologic agents have actually been a cause of cutaneous vasculitis rather than a treatment. But we can still find some reports with the use of rituximab, TNF inhibitors, and to a much lesser degree IL-1 inhibitors and tocilizumab. In general, again, the consideration for use of a biologic agent in isolated cutaneous vasculitis should be extremely rare. This would be in instances where there's failure or intolerance of other options, or potentially in severe disease that's warranting the potential toxicity. So again, something like ulcerating disease, where again they have continued to have active disease through agents such as methotrexate, azathioprine, or potentially cyclophosphamide. And again, I would say that if the disease is really to the point where you're considering a biologic agent, we often have to reassess the possibility, is there actually a systemic disease or trigger that's causing this, that's making this, again, more difficult? So in conclusion, cutaneous vasculitis is very important because it is the most common manifestation that any of us will see. However, this can be seen in a diversity of settings. It can be isolated, it can be secondary, or it can be part of an underlying systemic vasculitis. It is important to recognize that this carries the potential for this to be a heralding feature of a much more serious underlying systemic disease, and we have to keep in mind the potential for asymptomatic kidney and lung involvement. So that at the time of presentation, we want to not only confirm that this is vasculitis, but rule out that the patient is in a setting where there's an immediate threat. In terms of considering the treatment of isolated cutaneous vasculitis, again, unfortunately, at this point in time, there is no current evidence-based optimal treatment. It is often difficult to treat, and we try and approach this in terms of trying to decide the least toxic option. Biologic agents, as of right now, do not yet have a clear role, but again, there is a lot of exciting movement in the vasculitis range that may make this a difference in the future. And again, although cutaneous vasculitis in isolation, it is uncommon for it to evolve to a systemic disease, this still can occur, making our vigilance as far as listening to new evidence for symptoms or signs and weighing whether the picture is changing, particularly important in following these patients over the course of time.